Welcome to your first lecture regarding Part 4 in your textbook, which is going to cover drugs affecting the cardiovascular and renal systems. A quick reflection. Lord, we pray for the protection of our students. We ask that you would guard their heart and their mind in Christ Jesus, that you would wrap them in your love and deliver them from all evil. Lord, we pray that you would give our students great enthusiasm for their studies. May you inspire them each and every day, and may each seminar and class bring fresh inspiration to their work. May each moment be filled with the energy they need for their tasks. Amen. I would also add on there, may my computer allow me to record this, as this will be the second or third time I've attempted to record this and my computer keeps shutting down on me. So keep your fingers crossed for me. I'm getting a little frustrated here. So the chapter we're covering today is antihypertensive medications, and I always really like talking about this for a couple of reasons. One, it doesn't matter what area of the healthcare system you go into, you're going to be dealing with these medications. And this is true if you're a nursing, respiratory therapist, physical therapist, or athletic trainer. It's really broad and applicable to a bunch of different disciplines. Also, focusing in on nursing, it doesn't matter what discipline of nursing you decide to go into, whether it's adult health, pediatrics, OB, prevention, school nursing, whatever you may go into, you're also going to be working with these medications. And the reason being is, unfortunately, with today's epidemic of obesity, there's not a age population which is exempt from this. It used to be that hypertension was essentially an old person's disease, so unless you were going into geriatric nursing, you didn't really have to worry about it. But unfortunately, we're seeing people diagnosed younger and younger with hypertension, all the way into the pediatric years. It's sadly not uncommon for a child to be diagnosed with hypertension and started on some of these medications. So no matter what discipline you go into, we're going to be working with these drugs. Just a few objectives before we get started. Briefly discuss the normal anatomy and physiology of the autonomic nervous system. So we're talking about the sympathetic and the parasympathetic and how they affect blood pressure control. Define hypertension, compare primary and secondary hypertension. List the criteria for the pressure values, because there's 3 different categories of hypertension. There's pre-hypertension, stage 1, and then stage 2, and they're all a little bit different, and they're treated just a little bit different as well. Use the most recent guidelines, compare the various drugs used in the pharmacologic management of hypertension, and this will be the objective we spend the most time on today. Discuss the rationale for non-pharmacologic management of hypertension, and then develop a nursing care plan that includes all phases of the nursing process for patients receiving the antihypertensive drugs. And this will kind of sprinkle throughout, so you'll be getting that kind of throughout the lecture as well. So hypertension, what is it? It is defined as the consistent elevation of systemic arterial blood pressure. And it's elevated, systolic above 140, diastolic greater than 90. Now with this, it has to be high on 2 separate occasions. So if somebody comes in, they have a high reading, we will have them come back at a later date for a confirmation of that diagnosis. So it's at least 2 elevated blood pressure readings. For the different classifications, we again have the 3. Prehypertension is defined as 120 to 139 over 80 to 90. At prehypertension, most of the time they'll just recommend lifestyle changes. So start exercising, limit your diet. They'll try some of those modifications first to see if they can bring the blood pressure down naturally. Now, if that doesn't work, they may start them on a medication to also help aid bringing the blood pressure down, because hypertension is not just caused by lifestyle factors. It can also be caused by genetics. So there are some people who are incredibly fit, they eat right, and they still have a high blood pressure. So for those, then they would need their medication to help control it. The next stage is stage 1, and this is defined as a blood pressure of 140 to 159 over 90 to 99. Now, if somebody comes in and it's determined they have stage 1 hypertension, they're still going to suggest lifestyle changes, but they'll probably also start them on one medication to aid bringing it down. We like to get that back down to less than 120 over 80, but for sure less than 140 over 90, because at that range, the 140 over 90 is when we start seeing target organ damage. So if it's sustained at that rate for a duration of time, you'll start seeing that there's some permanent damages being done. So at stage 1, we start throwing in some medications to bring it down quicker. Now, stage 2 is defined as a blood pressure of greater than 160 over 100. At this time, there's a high incidence of end organ or target organ damage being done. So at stage 2, they'll typically still do the lifestyle changes, but then they're probably also going to start the patient on at least 2 different types of antihypertensive medications. And when they select their antihypertensive medications, if they're doing 2, they want 2 that have a different mechanism of action. So they might have one that's a diuretic and they might have one that's a vasodilator to help increase the likelihood of it helping. Just a couple of statistics for you. Beginning at a pressure of 115 over 75, the risk of cardiovascular disease doubles with each additional increment of 20 over 10. So this means if my resting blood pressure is at 115 over 75, and then it raises to 135 over 85, still not a scary high blood pressure, but my risk for cardiovascular disease has doubled from what it was. Now, if it goes up to 155 over 95, my risk has quadrupled. So it starts increasing significantly when you start going up. And like I said, even a blood pressure of 155 over 85, a lot of people look at it and go, that's not so bad. And we need to change that mind frame in America that no, resting blood pressures in the 130s over 80s is high. We want that decreased. Even 20 years ago, the rule of thumb for blood pressure readings was they would take your age and then add 100 to it, and that's what was quote unquote normal for you. So if you were 80, it was normal to have a blood pressure of 180 over whatever, so they weren't treating it as aggressively as they are now. When I went through school, even in the last 10 years, the normal was 120 over 80. And we're seeing even that they're saying, nope, there's still damage, we want it lower than that. So I think you're going to see with your practice that there's a lot of emphasis on the lower, the better. Which of course, the lower you go, the harder that is for people to achieve because we're asking more of them. So that gets kind of difficult too. But individuals with a systolic blood pressure of 120 to 139 or a diastolic blood pressure of 80 to 89 are prehypertensive, and they're considered to be at risk for their target organ damage. So that's why we're working on getting it below 120 over 80. The scary statistics are 20% of Americans are prehypertensive and they don't know it. Setting those 20% aside, 1 in 3 or another 33% of Americans have been diagnosed with hypertension, and some of them know it and some of them don't. But that's a really scary statistic to look at from a public health standpoint. Just a few facts, and I am going to throw a disclaimer that these are about 3 years old, so they probably changed, but just to bring into focus again how big of a problem this is. Hypertension affects more than 70 million American adults. Again, about 1 in 3. The people who have the highest risk are going to be African American males. Being of African descent increases the risk of developing hypertension. It's a genetic thing. And then being male also increases the risk of hypertension. So African American males have a double whammy against them, and they're the ones who tend to have the most difficult to control blood pressure, and they tend to be diagnosed a little bit earlier in life. Among people who have hypertension, 28% of them do not know it. So if they don't know it, then that means they're probably not doing anything to treat or control it. So they're probably not watching their diet, they're probably not exercising, they're certainly not on a medication for it. And those are the people who die suddenly of a heart attack, and the family will say, but he was healthy, or we didn't know. The disease had probably been there for a long time, and it had just never been diagnosed. So it puts a lot of emphasis on screening individuals to try to catch it when their blood pressure is starting to eke up, and then that way we don't have those catastrophic, surprising events. About 54,000 Americans die each year from hypertension alone, and then it's estimated that's a contributing factor in an additional 300,000 deaths each year. So as a contributing factor, this would be people who died of heart failure that was brought on by hypertension, or by coronary artery disease that was caused by hypertension, those types of people. So what causes it? Factors responsible for blood pressure, and I've got number 1, little numeral 1 and 2 flopped around on your outline. But blood pressure, most simply put, is the cardiac output times the peripheral resistance. And we define cardiac output simply as the heart rate times the stroke volume. So our medications are going to act on one of those functionings. You're going to see that, like our beta blockers that we've already talked about, decrease the heart rate. So by decreasing the heart rate, they decrease the cardiac output, which decreases the blood pressure. Other medications decrease the volume of blood, which decreases stroke volume and peripheral resistance. So it's decreasing both cardiac output, peripheral resistance, and it's managing blood pressure rather well. A little bit about peripheral resistance. The way this works is there's many factors, but only 2 that we're going to focus on today. The first one being the size of the vessel, and the second one being the amount of fluid going through that vessel. So in regards to the size of the vessel, the larger the vessel, the lower the resistance. And if you think of this like, say you have a funnel, you have 2 funnels full of water, one has a really big opening and one has a tiny opening. Which one takes the longer for the water to go through? The one with the smaller or the constricted opening. That smaller opening with pressure against it is going to increase the pressure exerted on that vessel now we're talking about. So therefore, the more dilated or the larger the diameter of the blood vessel, the lower the blood pressure. So you'll see a lot of our medications are working on vasodilation. In fact, it's its very own category of medications. The next factor is going to be the blood volume. Now for this analogy, I want you to think, say you have your garden hose and you got hooked up to the spigot. If you turn the spigot just on slightly, like half on, your water just kind of dribbles out the end. There's not a lot of pressure there. It's good for watering your tender flowers. But now say you want to increase the pressure because you're going to shoot your brother who's across the fence. You're going to turn the nozzle way up to increase the volume going through there, and it's going to shoot out at a higher pressure, so it goes further. Kind of the same thing here. If we decrease the blood volume, it decreases the peripheral resistance. Now there's a mistake on your outline, or on the screen there. The smaller the blood volume, the decreased peripheral resistance. The larger the blood volume, the increase in resistance. So again, if you turn the spigot all the way on, you have more volume going through there. Your water is going to shoot out at a higher pressure. If you turn that spigot down, it's going to be a lower pressure, less blood volume in this case, and it's going to decrease your blood pressure. If that helps you kind of think about it there. As far as the physiologic regulation of blood pressure, it's the balance between the endocrine system and the nervous system. Focusing on the nervous system, it's controlled between the sympathetic and the parasympathetic nervous system. So these 2 are constantly firing to achieve what we call homeostasis, which is what your body perceives to be a normal blood pressure. So if your blood pressure gets too low, your nervous system fires some norepinephrine around and it brings it back up. If it gets too high, it stops its norepinephrine, which allows acetylcholine, or your parasympathetic nervous system, to take over, and it starts relaxing your vessels and bringing it back down. It's just a constant balance between the 2. A lot of our medications work on blocking that sympathetic nervous system to bring it down. So that's an example where we're manipulating the nervous system for a specific outcome. The flip side of that is going to be the endocrine system. Now the endocrine system is going to be a little bit slower of a reaction. So this would be, say you have chronically low blood pressure. Then your kidneys are going to secrete the hormone aldosterone to increase blood volume and cause vasoconstriction to bring your blood pressure back up. But it takes it a little bit longer to kick in. Our medications which act on the endocrine system to alter blood pressure are also going to be a little bit slower kicking in too. But they work pretty well. The hormones which affect blood pressure include epinephrine and norepinephrine, which are both a hormone and a neurotransmitter, which works on the sympathetic nervous system. But then more specifically, the hormones aldosterone and antidiuretic hormone. When you increase those 2 in the system, it causes vasoconstriction, which increases your peripheral resistance, which increases your blood pressure. And then it also causes fluid and water to be retained, which is going to increase your blood volume, which is going to increase your peripheral resistance, which is going to increase your blood pressure. So 2 specific categories we're going to talk about focus simply on the endocrine system and blocking that. So it's going to block ADH and block aldosterone, resulting in vasodilation and a reduced blood volume. Now the blood volume we're getting rid of isn't the important stuff like the hematocrit, hemoglobin, red blood cells, that kind of stuff. It's just the excess water, the fluid component of the blood that we get rid of. And if it's not in the blood, it comes out of the body as urine. So those medications make you urinate more. So just a quick kind of for people who are visual, the formula for blood pressure. Again, it's BP, or blood pressure, is equal to the heart rate times the stroke volume times the peripheral resistance. Your heart rate times stroke volume is also known as your cardiac output. And I found this YouTube video that if you are a little bit confused as to what I've been saying so far, it might be worth your time just to pause the presentation, watch this video. It'll give you a visual diagram of what I just described, and then come back to the presentation so that you understand when I'm saying, oh, this does vasodilation, you understand what's happening in the body. So a few minutes on the etiology of blood pressure. We've got primary versus secondary. Primary hypertension is going to account for about 90% of our cases. This is blood pressure that we don't really have a known identified cause. It could be lifestyle, it could be genetic. We don't know if it's a vasoconstriction, if it's a sympathetic problem, if it's fluid retention. We don't know. That's where most of our hypertension, somebody's diagnosed with hypertension, that's typically where it falls to. To treat primary hypertension, we just pick a medication and we try it, and if it works, great. If it doesn't, when they come back, we switch those medications around. Now, secondary hypertension is hypertension where we know what causes it, and it's typically caused by either a tumor on an adrenal gland, Cushing syndrome, which can be caused by a corticosteroid, or a tumor, hyperthyroidism, chronic renal disease, whatever it is, we know what causes it. So for secondary hypertension, they might go on an antihypertensive medication, but more likely they're going to try to correct the underlying cause. By correcting the underlying cause, then the blood pressure will come back to normal because there's nothing else holding it up. And again, that's only about 10% of our cases. The 4 target organs that really pay the price for high blood pressure are going to be the heart, kidneys, brain, and retina. Now your heart, increasing the blood pressure is going to make your heart work harder. And it's kind of like increasing the weights at a gym makes your muscles work harder, except for when your heart works harder, it doesn't get bigger and stronger, it gets bigger and floppier. So it becomes less efficient, which then leads to heart failure. So a high pressure on the heart is not a good thing. We really want it low pressure and let it do its thing. The kidneys, if they have sustained hypertension going towards the kidneys, they're very delicate little creatures, so any sort of pressure on them starts destroying the nephrons, and as the nephrons and the tubules get destroyed, it decreases the kidney's ability to filter blood. As you decrease your ability to filter blood, pretty soon water, sodium, all your electrolytes are being retained, so it increases the blood pressure, but then can also lead to cardiac dysrhythmias as potassium gets too high. It screws with the body's pH and does a whole bunch of terrible things. We really do worry a lot about the kidneys when we're talking hypertension. This is one of the big reasons why we keep the blood pressure as low as we can go while keeping the patient still upright. The next organ is going to be the brain. And what happens when you have a high pressure towards the brain is, again, it destroys the little arterioles that supply blood to the brain, and as those arterioles get destroyed, it decreases the blood flow because they become more of a fixed vasoconstricted state. So as they vasoconstrict and they just stay that way, it shunts blood away because if blood can't feasibly go through there, it's just going to take the path of least resistance and go more towards a bigger vessel. So when that happens, then you have a stroke or a TIA or something of that nature. And then the last one is the retina. Again, the retinas have very little blood vessels, so as those vessels get destroyed, it doesn't take much damage at all for blood to just be shunted away from there. And then the patient ends up with blindness as a manifestation of their hypertension. This damage is typically irreversible, so once it's been done, it's done. And that's another reason why we worry so much and we try to keep the blood pressure as low as we can. Non-pharmacologic treatment, you'll need to know just a little bit about this, although this is a pharm class and we're going to work on pharm. Understand that a lot of times we'll use our non-pharmacologic treatment in conjunction with our drugs. And the reason why is our drugs will work the best when the patient's also following a healthy lifestyle. So we encourage them to maintain a healthy weight. The less body surface area, the less work the body has to do to produce blood and supply blood to all the tissues. We also really focus in on their diet, and we encourage a limited intake of alcohol because alcohol damages blood vessels, and as those vessels get damaged, they become fixed and constricted, which increases your blood pressure. We also limit the intake of sodium because water follows sodium or water follows salt. So if you have a high sodium diet, typically the patient will also retain fluid, and as it retains fluid, increases the blood volume, which is going to increase peripheral resistance, which will then increase the blood pressure itself. And then we also encourage a low diet in saturated fats and cholesterol. Not that those two substances directly increase the blood pressure, but what happens if they have a high diet of saturated fats and cholesterol is those saturated fats stick to the edges of the blood vessels, and then we have what we call a plaque formation. When you have a high blood pressure coming against that plaque, eventually that plaque's going to break off and start traveling around the body. Once that plaque becomes wedged into a smaller arteriole, it occludes blood flow, and then you have your heart attacks, strokes, pulmonary embolisms, those types of events. So just to be safe, we say decrease that as much as possible. The next thing is tobacco products, which contain nicotine. And nicotine is a vasoconstrictor. So if you're ingesting nicotine via cigarette, chewing tobacco, even a patch, a smoking cessation patch that has nicotine in it, it's going to cause your vessels to constrict. And as you constrict your vessels, it increases resistance, which increases the pressure. And then the last one there is caffeine. And the studies are mixed on caffeine. If the patient can live without it, we say do so because it is a vasoconstrictor and it can potentially increase blood pressure. However, the studies are mixed. Some studies say, yes, caffeine is a vasoconstrictor and by decreasing it, you help your blood pressure a lot. Other studies say that the vasoconstriction action of caffeine is so minimal that it doesn't matter. It doesn't matter if they drink coffee or not. And some people go down the center and say, limit yourself to no more than 2 cups of coffee per day. So it kind of depends a little bit on the healthcare practitioner. It's probably not the healthiest thing to be taking in, but honestly, if you're going to choose between caffeine or sodium, I would limit the sodium and leave the coffee alone. And that could be because I'm a coffee drinker and I couldn't live without coffee. I would rather have a stroke than not have coffee. Our next point is to increase aerobic physical activity. So this is going to be stuff that gets your heart rate increased and keeps your heart increased. So think brisk walking, jogging, dancing, rollerblading, those types of activities. Weightlifting, although it's good to do, doesn't count for bringing down blood pressure because it just doesn't. We need the heart rate sustained. It needs to be sustained. I think the guidelines are still 30 minutes 5 times a week or something along those lines. So frequent exercise is good. And then the point number 4, reducing stress and developing coping strategies, isn't a bad thing to do. But the studies are mixed on how effective it is. Some studies say, yep, stressful lifestyle will for sure lead to hypertension and it's a bad thing. And others say the amount of stress or the stress encountered in life is not enough to increase the blood pressure significantly, so it doesn't matter. Again, it's probably not a bad idea to decrease stress, but how much it helps blood pressure, I don't really know. So, with all that information, there will be times when you have to select which medication you're going to use. And this is one for physicians, and for those of you who wish to go on to be a nurse practitioner, you'll have to be able to make an educated guess. However, even for those of you who have no desire to go on, if you work in a hospital setting, you will at some point be faced with a patient with high blood pressure, and the doctor will have left an orders a mile long as to what to give the patient because they don't want to be called in the middle of the night. So you'll be sitting there at 2 a.m. with a high blood pressure and 4 or 5 different antihypertensive medications, and you have to decide which one you're going to use. So the first thing is cause. If we know, like say this is a heart failure patient, we know they're retaining fluid, we're probably going to select a medication which is going to diurese the patient and get rid of the fluid because we know that's the cause. If you have a patient who's anxious because they're going to surgery, then you might select a beta blocker to help decrease the sympathetic nervous system. So sometimes you can make a pretty good educated guess, and other times you might have a blood pressure of 205 over 102 and a pulse of 45. At that point, you don't want to give a beta blocker because it's going to lower the blood pressure too low, or it's going to lower the pulse too low, but you certainly can't leave that blood pressure alone. So then you're going to go with a medication which lowers the blood pressure but doesn't affect the pulse. So there will be times when you have to critically think, well, which one should I give? What is safest to give? And it is expected, just as a floor nurse, that you be able to make those judgment calls and make sound judgment calls. Now, even with all that information, sometimes it's a trial and error. You'll try one, you'll recheck it, the blood pressure will still be high, and you'll choose another one. Another one that's not going to affect you as much as a floor nurse, but if you go on to become a nurse practitioner, will be the cost of medications. As a general rule of thumb, the older the medication, the less expensive it is. The newer the medication, the more expensive it is. And that will become a factor if you have patients who either have poor insurance or no insurance. It's better to get them a medication that they can afford and they will take, even if it's not the latest and greatest, than to give them the latest and greatest and have them not fill it, and then they don't take it and it does no good and they keep their hypertension. So keep that in mind as well. And the last one's going to be side effects. Some of these medications are really known for their side effects and some are not. If you have somebody that they come in and you tell them they're pre-hypertensive or they're hypertensive and it's decided they need a blood pressure medication, at stage 1 or pre-hypertension, they're not going to feel anything. It's asymptomatic, they're not going to feel anything, but they might humor you and go on their medication anyway because they're educated and they understand the importance of keeping their blood pressure low. But if one of the side effects happens to be sexual dysfunction and they had a satisfactory bedroom life and suddenly they don't, do you think they're going to keep taking it or are they going to stop? So that's something that if you suddenly have blood pressure that's not controlled, make sure your patient hasn't just stopped taking their medication because of side effects. Another common one is a lot of these medications, particularly beta blockers, make patients very tired during the day. And they'll go off their medication because they're so tired they can't get anything done. So that would be another instance. So just keep in your background of your mind that some of the side effects may cause them to go off their blood pressure meds. And then just a little bit on it's good to be a dipper. So what I'm saying with dipping is that it's certainly not tobacco dipping. For anybody, if they're hypertensive or not, your blood pressure naturally increases during the day and it stays elevated while you're up and doing stuff. And then when you lay down, it naturally dips. That's what we're calling a dipper. Somebody who still has the ability that when they lay down, their blood pressure dips. Patients who are non-dippers, their blood pressure stays high all the time. Their body never gets that reprieve from their high blood pressure. Patients who are dippers will typically just take their blood pressure medication in the morning. And they'll do so that as they're taking or as they're starting their day and their blood pressure is starting to increase, the medication will start working and then it'll help bring it back down. And then at night they probably don't need anything, so they can have a drug holiday overnight from their medication. Your non-dippers will be the patients who are on the medication both morning and at night because they need that double dose to keep it down. If they just take their blood pressure medication in the morning, their blood pressure will stay low during the day, but then when they go to bed at night, it jumps right back up and then they'll have that resting high blood pressure, which we don't want. So that's the difference between dipping and non-dipping. So with all that information, let's go ahead and step into our medications. The first group we've talked about, so this will be a review for you guys, which will be good. We're talking about our adrenergic drugs, and I'm just calling adrenergic agents at this point, not agonists or antagonists, because as you see there, we have both listed. The first one is going to be the exception to the rule, and then the last three are going to be the rule that we typically follow. But we have our centrally acting alpha-2 agonist, peripherally acting alpha-1 antagonist, peripherally acting beta receptor blockers or antagonists, and then we have some that act on both alpha-1 and beta receptors as well. And these were all covered between chapters 18 to 21, and you might want to grab chapter 18 when we talk about where the different receptors are located to help guide you through these next couple slides. So starting with the mechanism of action, the centrally acting alpha-2 agonist. Now these are the weird ones, because typically when you think an agonist to a sympathetic nervous system, you think you're making the fight or flight fire. Now because these are centrally acting, they're acting in the brain, and they're acting on alpha-2 only, so the alpha-2 receptors within the brain. When these are stimulated, it actually reduces the amount of norepinephrine available. Remember, norepinephrine is a neurotransmitter which causes the fight or flight reflex or nervous system to fire. So if you don't have norepinephrine, it inhibits your body's ability to utilize its fight or flight mechanism. So your centrally acting alpha-2 agonist, when stimulated, it suppresses the amount of norepinephrine available. By doing this, it reduces the blood pressure, and then it also reduces the activity of renin. Renin is a hormone secreted by the kidneys that causes both aldosterone and ADH to be secreted. ADH is going to prevent the diuresis, so it increases the blood volume, which increases resistance, which increases blood pressure. And then aldosterone both causes fluid to be retained, and then it also is a potent vasoconstrictor, so it's working on both mechanisms to increase peripheral resistance. So by blocking norepinephrine, you block the activity of renin, which therefore you block aldosterone, you block ADH as well. The two drugs, and we'll cover these in more detail when we go through our drug profile, are clonidine and methyldopa. And this is a very old category of medications. We have newer and better ones, but there are some patients that for some reason this just works best for them, and you'll still see it used every so often just because it's what works for that particular patient. Now all the rest are going to follow the rule that if you block the sympathetic nervous system, you're going to block that fight or flight. So your peripherally acting alpha-1 antagonists are only working on the alpha-1 receptors. And by only blocking those alpha-1 receptors, it's going to result in a dilation of the arterioles and veins, which reduces your peripheral resistance to reduce blood pressure. And that's also going to increase the blood flow to the kidneys. When blood flow is increased to the kidneys, it stops the signal to produce renin, so then you're not having the aldosterone and the ADH secreted, which then reduces blood volume and peripheral resistance. So it's working mostly on reducing the peripheral resistance component of your blood pressure equation. The other thing that this group of medications does is it prevents smooth muscle contraction. And by doing that, it mostly does that within the bladder and the urethra and the prostate gland. So blocking the contraction of that smooth muscle is how these medications work for BPH. So this is the same group of medications that Flomax belongs to, if you remember Flomax from the previous test. And all the medications which fall within the peripherally acting alpha-1 antagonist kind of sound alike. They all have that zocin in their name. That would be the doxazocin, prazosin, and terazosin. And we'll talk, I think doxazocin is the one that your book profiles. So we'll talk about that a little bit more in just a few minutes. The next group is going to be acting on the beta receptors. And to be honest, as long as you can tell me a drug is acting on the beta receptors, I don't terribly care if you can tell me whether or not it's a selective beta blocker or a non-selective beta blocker. And the reason why I don't really care if you can identify if it's selective or non-selective is because at a high enough dose, your selective beta blockers will become non-selective. So then they'll be working on both receptors. Following that line of thought, we teach you to anticipate the side effects from both beta 1 and beta 2, just in case that patient is sensitive to that type of medication. So for that reason, I don't care if you can identify a medication as a beta blocker. I'm happy. I'm not going to get particulars of selective or non-selective. If you take a higher course, then you will get particular, but right now we're not. So these drugs all work by blocking beta cells within the peripheral. The ones which are working on beta-1 only are going to work primarily on the heart and the kidneys. Acting on the heart, they're going to decrease contractility, and they're going to decrease heart rate. By doing this, they decrease the cardiac output, which then decreases the blood pressure. They're also found on the kidneys though, because beta-1 typically are heart and a kidney type receptor. And when you suppress the beta receptors on the kidneys, it decreases the renin secretion, which then decreases aldosterone and ADH, which decreases peripheral resistance. So when you administer even a selective beta blocker, it's working to decrease the cardiac output, and it's decreasing the peripheral resistance. So it's working on two mechanisms to bring down the blood pressure. For this reason, your beta blockers are typically a first-line medication for patients, unless there's a reason not to use it. They're good little drugs. Your ones which are selective are going to be your atenolol and metoprolol. Propranolol, you can actually make a little arrow down. That's a non-selective one, but the other two are selective. Again, I don't really care if you can tell me if they're selective or non-selective, but if you're into details and you want to know, that's how that divides out. Your beta-1 and beta-2 receptors are going to, blockers are going to work on beta-1, so it's going to do what we just said, plus it's going to be working on the beta receptors, which are located in the blood vessels and the lungs and the liver. Now, working on the beta receptors within the blood vessels, it's going to result in vasodilation, which decreases peripheral resistance and brings down the blood pressure with yet another mechanism. However, some of your side effects come from the ones located within the liver and the lungs. The ones which are located in the liver, when they're stimulated, so when you agonize them, it releases glucose, which then keeps your blood sugar within a normal level. When you take away the body's ability to release some of that glucose, you run the risk of hypoglycemia. So therefore, these medications have a side effect of hypoglycemia, and they're used with caution in diabetic patients. The other thing that we worry about are the beta receptors located within the lungs, because when you stimulate these, it causes bronchoconstriction. Now, if a patient doesn't have asthma, it's not going to matter to them. It's not going to be enough that it affects them. But if they have asthma and they're already predisposed to having bronchoconstriction attacks, these medications can trigger an asthmatic attack. So for that reason, we use them cautiously in patients who are asthmatic and patients who are diagnosed with COPD because they also have problems breathing. And then the last place, there are beta-2 receptors located in the muscles. When you stimulate it, relaxes smooth muscles, brings down the blood pressure a little bit, but not a ton, but it does work in that aspect as well. Again, your propranolol will be your non-selective beta blocker. Atenolol and metoprolol are working mostly on the first one. The last group we have to talk about are ones that are like your superstar of this group, and they work on both alpha-1 receptors and both beta receptors. So we call them a peripherally acting dual alpha-1 and beta receptor antagonist. So they're an antagonist to both alpha-1 and that should be both beta receptors, not both beta receptors. So they're going to act in all of the above manners. And just as a little bit of a synopsis of what we just said, they're going to dilate blood vessels, they're going to reduce heart rate and contractility, they're going to increase renal blood flow, which decreases renin secretion, but then they also have the ability to cause bronchoconstriction and inhibit the release of glucose from the liver. For that reason, these are also used cautiously in patients who are asthmatic and diabetic. Now you'll note your alpha-1 antagonists, just working on alpha-1s like your doxazosin, terazosin, those don't have those side effects. Those are safe to use in asthmatic and diabetic patients, but these, when they're acting on the beta receptors, are not as safe. With these, they're fairly easy to identify. So your beta blockers that they just are working on beta end in OLOL. The ones which are dual acting, alpha-1 and both beta, end in LOL. So it just doesn't have that first O in there. So if you want to make that little note that they're fairly easy to identify, that without that extra O, they're a dual acting medication. So talking about general indications and general contraindications for your adrenergic agents. So now we're talking about all four categories again for the most part. Hypertension is why we're focused on them today. They also have value in treating glaucoma, which reduces the pressure within the eye. And then your alpha-1 antagonists are also indicated for the treatment of BPH. That will be the only one of the four groups which is indicated for BPH. The rest are not. The next one's going to be heart failure, but there's only 3 beta blockers, and one of them is a dual-acting beta blocker and alpha blocker that are indicated for heart failure. So heart failure becomes both an indication and a contraindication. I would really highlight those 3 beta blockers that are indicated for heart failure and know them, because that will be a test question. Somewhere on your exam, you're going to have to be able to identify if it's safe for patients with heart failure or not. Now, you will see a little bit of a change in practice in the fact that our beta blockers are becoming more safe, and they're starting to make them more friendly for heart failure patients. And your book talks a little bit about this, but I'm going to stick with the rule of thumb that it's only those 3 and no others, because our practice really hasn't evolved to where we have totally safe beta blockers, and the studies are still mixed. So for your exam, I want you to just know those 3, and if I ask you which ones are safe, go to that list. Now understand, when you hit practice, as new research comes out, this list may change, but the change has not been made official yet. So that's just my little friendly warning. There's a couple off-label uses, and the difference between a label and an off-label use is a label has the FDA stamp of approval, the off-label does not, but we still frequently use beta blockers for the prevention of migraines and then also to help control anxiety. Some of the general contraindications include allergy and then heart failure. Again, know the 3 that can be used for heart failure, and all the others like atenolol, propranolol are a no-go. We don't give those for heart failure patients. Asthma and COPD, it's not that they will never ever be used, but we use them with caution. You might have an asthmatic patient who is on a beta blocker, but it's used with caution, and we encourage them to have that albuterol close to them in case they have an attack. Same thing with diabetic patients. It's not that they won't ever use them, it's just used with extreme caution. And I would also know the contraindications. I would highlight heart failure, asthma, COPD, and diabetic patients, because there will be questions which ask you to identify which category of patients shouldn't be getting a beta blocker or which one needs extra monitoring. And that's what you're going to be thinking. If they have those extra comorbidities, you need to be thinking, oh, this isn't a good medication. Sometimes it's a matter of double checking, confirming with the doctor. And sometimes it's a matter of they're having difficulty breathing. I can't give this. I cannot safely give this medication. So going on to your adverse effects, I've got this kind of delineated out to the different receptors. Blocking all of these receptors causes hypotension. So that's your first fill in the blank, is hypotension. For this reason, you always need to check their blood pressure, and if it's low, and the rule of thumb is if it's less than 100/70 to hold it. If it's greater than 170, I would still give the medication, because if you start holding these medications, it can result in a rebound hypertension and tachycardia. So 100/70 tends to be the magic cutoff. We worry more about the top number than the bottom number when we're trying to decide if we're going to give or not give, though. But 100 tends to be the magic cutoff for it. The next, also with hypotension, it's going to cause dizziness. So make sure that you're standing with your patients, because they're going to get, when they stand up, get orthostatic hypotension and get dizzy, and they can pass out. So that becomes a safety consideration. So just assist them to the bathroom, assist them to stand, tell them the first time you get up kind of slow because you'll get dizzy. Just be aware of that. And then the next one is sexual dysfunction. Because of the hypotension, it's going to cause most likely sexual dysfunction. Kind of embarrassing to ask about, but make sure you're acknowledging it, because you don't want a patient to go off their medication for this reason and then have a catastrophic event. The urinary incontinence, I have an asterisk there because it's not common. It's something that it could potentially, in this realm of reasonable things, happen, but it's not likely. And then the hypoglycemia, we worry more about diabetic patients. One, can inhibit the body's ability to compensate for hypoglycemia. And 2, it can mask some of the early signs and symptoms of hypoglycemia, like the tachycardia, sweating, anxiety, that kind of stuff. Beta, and that would be more of a beta thing instead of an alpha thing. I'm not quite sure why that wandered up to alpha. For your beta 1, definitely bradycardia, hypotension. So for bradycardia, check the pulse. And if it's less than 60 to 55, I will hold this. If I have a resting pulse of 51, I normally will not give the beta blocker because you have to think cause and effect. If I give this, the pulse is going to decrease to the 40s. Is a pulse of 40 beats or within the 40 beat per minute realm, is that sustainable with life? Probably not. It's not that they're going to die, but they'll probably pass out from it. So therefore, if the pulse is less than 55, I personally won't give it and I'll hold it per nursing discretion. Same rules for hypotension apply there. They'll get dizzy if their blood pressure is less than 100/70. Hold the medication. And then beta 2 tends to be our problem child. Still going to cause some hypotension, but more likely to cause a hypoglycemia in the bronchoconstriction. So just be mindful of asthmatic patients and diabetic patients. And then just a couple general things from suppressing the sympathetic nervous system can cause a little bit of, it shouldn't be so much a dry mouth for blocking the sympathetic nervous system. Dry mouth, constipation. The one that from that list, and I just pulled this from your book without looking at it too hard, the one I really want you to remember is the lethargy and the tired feeling. It's not unusual because you're blocking norepinephrine, and think back to our lecture over psych meds and how norepinephrine was related as a neurotransmitter to psych meds. The same thing goes here. With norepinephrine, when you inhibit norepinephrine, you inhibit the body's ability to be alert. So it's not unusual for patients to come in for their checkup and their blood pressure be fine, but they'll say, I'm so tired, I feel like I have no energy, no motivation. That no energy, no motivation is very characteristic of a beta blocker. Sometimes it gets better with time, and sometimes it doesn't. If it doesn't get better with time, they may need to have a different medication that's more suitable to their life. Because again, you don't want them to go off their medication because they can't stand being tired all the time. And that would be a big deal for me. If I always felt like I was tired and I had all this stuff to do, I probably wouldn't take my medication because getting stuff done is more important. Sadly, apparently is more important to me than keeping my blood pressure low. But you just have to be aware. Busy people aren't going to like not being able to get up and move because it's going to interfere substantially with their life. And then the last thing I want to point out here, if these medications are stopped suddenly, it's going to result in rebound hypertension and tachycardia. For that reason, these medications are never, ever, ever stopped suddenly. If a patient suddenly can't eat or drink because they're in the hospital with some weird bowel thing happening, they get IV beta blockers. We don't stop these suddenly. They must be taken. If they get this rebound hypertension, the risk of having a heart attack, a stroke, renal dysfunction increases so astronomically that it's ridiculous. So really stress that it's so important for your safety to always take these medications. If you run out, you need to call right away to get a refill. If something happens and you don't want to take this medication, you need to come in right away so we can change it so you don't end up with a heart attack. That's something that's really, really important to stress. And again, something I'd probably highlight if I were you. Talking more specifically about your drugs. So the first one we have to cover is clonidine or catapress. Clonidine is an alpha-2 adrenergic receptor stimulator agonist. So this one is going to be the one that doesn't follow our rule. This is going to be weird. Clonidine is more commonly prescribed than methyldopa. Remember, there's both clonidine and methyldopa within this category. Clonidine tends to be a little bit more commonly prescribed because it has slightly better side effects and it's a little bit more efficient than methyldopa. However, where you will still see methyldopa, and Aldomet is the other name for it, it's ALDOMET. Methyldopa is still used in pregnant patients because we know it's safe. So sometimes women who develop preeclampsia will still get methyldopa because we know we can use it on them and it'll be okay. It's really not a first line due to the side effects, including hypotension, dizziness, fatigue, sexual dysfunction. When you weigh the benefit to the side effects occur too frequently and the benefit not really enough. So it lowers the blood pressure just enough to cause the side effects, but not enough to decrease the risk of having target organ damage in most patients. Now, eventually you'll come across somebody who's an exception to the rule, and for whatever reason, clonidine is the magic pill for them. Those patients will just leave them on clonidine if it's working. Just know for most of your patients, this isn't probably going to work very well. Indications, hypertension, and sometimes we'll use it for opiate withdrawal. And again, stopping it suddenly is going to cause rebound hypertension. So don't do it. Don't stop these suddenly. These can come in a patch form, IV form, or an oral form. The IV form is most likely going to be for patients going through opiate withdrawal. The oral tablet form is typically used for patients with hypertension. While the patch does exist, I've never seen it used, so I'm going to say it's probably not a very common route to use. The next group we have to cover is doxazosin or carduria. This is going to be your alpha-1 antagonist, and this is going to be in the same category as Flomax. So kind of think about Flomax in this one as far as being in the same category as we go through here. How this works is it reduces peripheral vascular resistance. So if you look at our low blood pressure medication, it's working on this last component of it to decrease the blood pressure. It's indicated for hypertension, and then the only one that's used for BPH is Flomax. The rest of them are not that great at lowering or at improving prostate function, but Flomax just happens to be the one that's really sensitive to those within the prostate gland. The rest of these are working mostly on the peripheral vasculature. This comes in two forms, both oral. One's an immediate release formation and the other one is an extended release. Now with the extended release, just as a friendly reminder, don't crush that pill. So if for some reason the patient couldn't swallow, they would need to be switched to a different medication or to an immediate release formation. The other thing with the extended release formation, this is pretty true for any extended release, not all, but many of them. The shell of the pill is not dissolved by the GI content. So what happens, the patient takes the pill, it breaks into two, and the inside of it gets absorbed, but there's still what we call a shell, or a ghost pill. Patients will get really freaked out when they go to the bathroom, have a bowel movement, and they see their pill in their toilet, and it might freak them out and cause them to call the doctor because they think something's wrong. So just so you don't scare your patients, let them know that the shell will appear in the toilet and nothing to be alarmed about. It broke apart, it did get absorbed. It's just the way these pills work. So it's kind of like corn in that matter. The shell just shows up. The next one is a relatively new beta blocker, and it's kind of an exciting one. The trade name is Bystolic, and Bystolic is a beta-1 selective antagonist, so it's a beta blocker. It's the newest on the market, and what makes this guy so special? And you certainly don't have to be able to repeat this because I actually have to read it to get it right. But it produces endothelium-derived nitric acid-dependent vasodilation. What I want you to think about that in addition to being really good at decreasing heart rate and contractility, this is also really good at decreasing systemic vascular resistance. So this guy is working on both the heart rate, the stroke volume, and the peripheral resistance to lower blood pressure. For that reason, this is a really good medication to use. So just keep that in mind. This is a really, really good medication, and it's brand spanking new, which means it's kind of expensive. But I think we're going to see this one used a lot more, and hopefully it replaces atenolol as a beta blocker. The other nice thing about this is it doesn't cause as many side effects, particularly the sexual dysfunction. As with the other beta blockers, though, we certainly don't want you to stop them suddenly. So if you stop this suddenly, it's going to cause the rebound tachycardia, rebound hypertension, it's going to cause problems. But that's Bystolic. The next one are all ones we've covered, and I've just left the either OLOL or LOL unhighlighted so you can kind of see what I'm talking about when I say they end in LOL or OLOL. I have to laugh because I thought that was really clear to people, and then I had a student tell me that she went to a conference and she thought that this was such a good hint, and I was like, I told you that I don't know how many times. And she's like, yeah, but I never really knew what you were talking about. So this is what I'm talking about. The ending of the generic name will end in a specific way, and sometimes we can use this to figure out what the drug does. The first one, again, we've already covered it, so we'll just zip through it, is going to be atenolol, used in the treatment of hypertension and angina, which is just chest pain. It's a cardioselective, meaning it should only be working on the first one, but it does have the potential to stimulate or to block the beta 2 as well. So we still use it in classical diabetic and asthmatic patients. For that reason, we always want you to check the blood pressure, check the pulse, and check the history of the patient to make sure they don't have those comorbidities. If the blood pressure or pulse is low, you won't give this. And then atenolol is the one that will decrease peripheral resistance, so like in the arms and legs, but it doesn't touch central resistance, so it still leaves a high pressure running towards the kidneys and the brain. For that reason, I suspect atenolol is going to kind of fall off the market and hopefully fall off of the popularity wagon. The next one's carvedilol. So this ends in the LO only, making it a dual action alpha-1 and a beta-1 and 2 antagonist. Carvedilol, nothing real special about it except for it's also used in the treatment of heart failure. This is one of the three. When it's used for heart failure, it will be combined with a different medication, which will be the next lecture's information, so I won't go too much into that right now. Other indications include hypertension, obviously heart failure, and angina, and again, this comes in an oral and a controlled release. Then the next one's labetalol. Labetalol is an old guy, and it's largely been replaced by carvedilol, but we still see it used in, like it's a favorite to use after surgery to bring blood pressure down from anesthesia. For some reason, it works really, really well there. The other time we'll use labetalol is when a patient comes in with a hypertensive emergency. In those two instances, labetalol works better than carvedilol. And one reason why we like it more than carvedilol in those instances is it comes in an IV form. Otherwise, for your patients who are just using it for maintenance therapy, they'll probably go to carvedilol. It's a dual action alpha-1 and beta antagonist used in the treatment of severe hypertension and then hypertensive emergencies. For the hypertensive emergencies, it's always going to be an IV administration. For the severe hypertension, that might be when they go home on the oral labetalol. But again, it's more common for them to go home on an oral carvedilol, just because it works a little bit better. The last two we have are metoprolol, which again is the most common beta blocker prescribed. It is cardioselective, but at a high enough dose, it will work on both receptors. This is really good for heart attacks. Afterward, it helps protect the heart, hypertension, and then heart failure as well. Routes include oral. There is IV low pressor, but you have to push it really, really slow because if you don't, it causes the patient to get really dizzy and pass out. And again, before you start the medication, you need to make sure that you're checking the pulse, checking the blood pressure. If the pulse or blood pressure is low, you certainly wouldn't want to give this medication. The last one's propranolol. This is an OLOL, so this is going to be a non-selective beta blocker, as is metoprolol. This is the oldest one on the market, but we still see it used fairly frequently because it works rather well. It's good for hypertension, and it's also really good for dysrhythmias. And sometimes we'll see it used in patients who are diagnosed with pheochromocytoma, which is a tumor that causes hormones to be secreted, which results in hypertension. So that would be an example of secondary hypertension, not primary hypertension. Well, those are all your adrenergic agents. Now we're going to move on to a brand new group that's kind of exciting to talk about new stuff, and this is going to be our ACE inhibitors. ACE stands for angiotensin converting enzyme inhibitor. So, just as your very fast patho lecture, because you may or may not have had this before. I imagine you probably were introduced to it in physiology, but I don't know. So I'm going to introduce it to you now. When your kidneys either have diminished blood flow, or if your body is perceiving your blood vessels to have a low pressure, it's going to secrete what we call angiotensiogen from the kidneys. Now, once that's secreted, it comes in contact with this renin. And when renin is contact, and actually I said this backwards, angiotensiogen, I don't know what secretes it, just floating in the body. Your kidneys in response to low blood pressure actually secrete renin. And then when renin comes in contact with this angiotensiogen, so the green word, it converts it to angiotensin 1. Now, when angiotensin comes in contact with this ACE enzyme, which just stands for angioconverting enzyme, it goes from 1 to 2. This angiotensin 2 is what does all the actions that increase the blood pressure. So it must hit this stage of having this angiotensin 2. This by itself is a vasoconstrictor, so it's going to make those vessels lower, which increases peripheral resistance, which increases blood pressure. It also secretes these two hormones, aldosterone, or it stimulates the secretion of aldosterone and ADH. Aldosterone causes water and sodium to be retained, plus aldosterone is also a vasoconstrictor. So it's increasing fluid volume, it's decreasing the vessel size, both of which increase the blood pressure. It's also increasing ADH, which is your antidiuretic hormone. I'm not really sure what this arginine vasopressin is, but the word we're talking about is the antidiuretic hormone. Antidiuretic hormone causes fluid to be retained, plus it's also a vasoconstrictor. So if we have an ACE inhibitor, this group of medications is working right here. By coming along here and inhibiting this enzyme, so it takes this out of the equation, renin is still secreted and floats around the body and causes a conversion from angiotensiogen to angiotensin 1. But then nothing else happens because the ACE is gone. So it stops it right here after this angiotensin 1. And that's where our ACE inhibitors are working. So keeping that in mind as we move forward. Okay, so it blocks the conversion of angiotensin 1 to angiotensin 2. Sodium and water retention are going to increase blood volume, which increases your peripheral resistance. So by blocking that conversion, you decrease the amount of blood volume retained. The other thing that does is it blocks ADH, and ADH naturally induces vasoconstriction, which increases blood peripheral resistance, plus it causes water and sodium retention. So your ACE inhibitors also block the ADH from occurring. So it's going to result in vasodilation and decreased blood volume, decreased resistance, decreased blood pressure. And then I just have that all kind of right here by this little point here. So you can just see these medications are largely working right here on the peripheral resistance. A little bit on the stroke volume by decreasing the blood volume, but they're mostly working on decreasing the peripheral resistance. Indications, or just a couple fun facts on these that I don't have on your outline, and that's okay, you don't need to write them down. These are actually developed from the venom in pit vipers. So if you hate snakes, you can thank them for one thing, and that's developing an ACE inhibitor. And then they're also typically used at the same time as a thiazide diuretic, which we'll get to in a next chapter, so we won't worry too much about that right now. Indications for this, big one for hypertension. It's a great one for patients to typically use in combination with a beta blocker, because remember your beta blockers are largely working on your heart rate and your stroke volume, and a little bit on your peripheral resistance, but then adding this would control both the heart rate, the stroke volume, and it decreases peripheral resistance. So for people who have complicated hypertension, they'll normally go on some sort of an adrenergic agent, plus they'll go on an ACE inhibitor. ACE inhibitors are also first line for hypertension, which is the next chapter we'll talk about, and then they're typically used after a heart attack to help protect the heart post-MI. Some of your contraindications here are going to be an allergy and then pregnancy. During, I think, the first trimester, it's actually a category C, but then the second two trimesters, so the second and the third one, it's a category D. For that reason, if somebody's pregnant, they absolutely cannot use an ACE inhibitor. So this is a medication you're probably not going to see used on the OBGYN floor. They also recommend patients avoid this during breastfeeding as well. If it's the only medication that works for them, they may consider it, but for the most part, they like to avoid this around anything that's going to come in contact with little people. The other thing that this medication causes, and what causes it to be a contraindication to those who have had it, is angioedema. Angioedema is simply, if you break it down, angio is small blood vessel and edema is going to be swelling. And where we see angioedema show up is around the lips and the eyes. So this is actually a picture of a patient who has undergone angioedema from her ACE inhibitor. If they ever have a history of angioedema, we use ACE inhibitors with severe caution because they typically trigger this again. This can escalate into an anaphylactic shock where the patient can't breathe, so it becomes a big deal whenever we change the dose of an ACE inhibitor, so if it gets increased, or the first time that they're on an ACE inhibitor to warn them. If you start having any tingling around the lips, if you have any difficulty breathing, you need to come to the emergency room ASAP because this is what this group of drugs is good at doing. The other contraindication with ACE inhibitors are patients who have hyperkalemia. And hyperkalemia is simply a serum blood level, potassium level of greater than 5.0. And this can be caused by diseases such as renal insufficiency, it can be caused by an overdose of potassium, and it can be caused by different types of medications, particularly potassium-sparing diuretics, which we'll talk about here after this lecture as well. So just keep in mind ACE inhibitors and high potassium don't play well together. What happens if a patient has a high potassium and they take an ACE inhibitor is it increases the potassium even more and it can cause a cardiac dysrhythmia. So that gets to be no good for them. Side effects all come from the vasodilation. So this is another thing that I want you to be able to remember, that when a drug causes vasodilation, it's automatically going to cause these 4 things, plus one more I'm going to have you write down. The first one is a headache, and how I remember this is if I don't get my coffee, I get a headache. The reason I get a headache if I don't have caffeine is a vasoconstrictor. So if the constriction decreases and my vessels dilate, it causes a headache. Same thing here, when the patient first starts taking an ACE inhibitor and they start having that vasodilation, they're probably going to have a headache. We normally recommend Tylenol because it's the safest for the cardio system if they need to take something to control that headache, but we do know it is going to cause that. The next thing is those vessels near the skin dilate as it causes flushing. So they're going to have a flushed face. Should go away the longer they're on the medication, the lower incidence of a headache and flushing because the body gets kind of tolerant to it. The next one's hypotension. As vessels dilate, the blood pressure drops. It's what we want, but it also becomes a side effect because if it drops too low, they'll have orthostatic hypotension and they'll get dizzy when they stand. We worry about dizziness when they stand because if they stand too fast, it can cause them to pass out, and that becomes a safety issue of them hitting their head. So we do worry about their blood pressure getting too low. The next one is rebound tachycardia, and this is simply the body trying to compensate for the drop in blood pressure. So naturally, as your blood pressure drops, it causes your heart rate to beat faster unless you're taking an agent that also suppresses the heart rate. So as your pressure drops, your pulse will increase because your body's trying to bring your blood pressure back up to what the body perceives it's normal to be. The rebound tachycardia isn't going to last long. Eventually the body gives up and just says whatever, and it will quit fighting the medication and it'll leave the pressure alone and it'll bring the heart rate back down. But immediately after giving this, or for the first couple doses, the body will fight it a little bit. So anytime vasodilation happens, those 4 clinical manifestations happen. The other thing that happens is peripheral edema, which somehow did not get added to your outline, but you can add it right now. So what happens, or how it causes peripheral edema, is those vessels, as they dilate, they become kind of permeable, and it allows fluid to seep from within your blood vessels to outside your blood vessels. What patients might complain about with this peripheral edema is their rings may not fit anymore, and their shoes might be a little bit tight. It's not enough to cause a significant, like you're not going to see deep pitting edema from it. It's just your patients might complain of those 2 things in their hands and their feet. The other thing I really want you to be aware of is that ACE inhibitors cause a cough. And the way I remember this is a little saying, give them an ACE and they'll cough in your face. Up to 20% of the population is going to develop a cough from the buildup of bradykinin. As this is inhibiting the ACE, that little angiotensin converting enzyme, it also increases the amount of bradykinin in the system. results in a cough. Patients will stop this medication because this is an uncontrollable, dry, hacking, annoying cough. If they develop a cough, we have a different medication that we'll put them on that acts similar to the ACE inhibitors that we'll cover in like 2 slides, 3 slides maybe. But really remember that. Give them an ACE and they'll cough in your face. So if a patient develops a cough after starting an antihypertensive medication, this is probably the one they were on. And that's something I will want you guys to remember. A couple other notables, hyperkalemia, most likely to occur in patients who are on a potassium-sparing diuretic or if they have a diet high in potassium. Angioedema is the swelling of the face, and that does become lethal if it's not treated. And then acute renal failure. Although these medications in healthy people probably won't cause renal failure, if they have any sort of pre-existing renal failure, it will make that condition worse. The other thing we worry about with ACE inhibitors and renal failure is if they're taking other nephrotoxic medications such as ibuprofen, Aleve, Advil, those types of medications, that can also induce renal failure. So just kind of have that tucked into the back of your mind as well. A few of the interactions with ACE inhibitors. Antihypertensive medications are going to cause the blood pressure to fall even lower. So that includes any of your adrenergic antagonists, your beta blockers, alpha blockers, or your alpha-2 agonists. Those are all going to increase the hypotensive effect of the medication. Sometimes we do this deliberately if the patient has uncontrolled or complex or stage 2 hypertension. But just keep in mind that as the blood pressure falls, the dizziness that's associated with a low blood pressure increases. So then we just want to make sure that we're staying with them as they stand up and they're not falling over. The next one's NSAID therapy. One, it reduces the effectiveness of ACE inhibitors, plus it also can induce renal failure. So we typically just tell patients don't take ibuprofen while you're taking this medication. Protect your kidneys, plus it helps the medication work a little bit better as well. And then being careful of medications which have potassium in it, potassium-sparing diuretics, and then potassium supplements. Okay, so the profiles. ACEs come up in April. They all end in that PRIL, so they're super easy to identify. And I've got them bolded on your PowerPoint, which now that I look at it, maybe I should have put them in green because the bold is a little hard to see. But you can see how they all end in that PRIL. So it doesn't matter what letters I put on the front part of that name. If it ends in PRIL, it's an ACE inhibitor, and it's going to follow the same rules that we've talked about. It's going to cause a cough. It's going to cause vasodilation. It's going to be used for hypertension or heart failure or something along those lines. The one that your book highlights is Cadopril, and this was actually the first ACE inhibitor on the market, and it has the shortest half-life. Now this becomes beneficial for patients who might be prone to renal dysfunction. Although we try to avoid ACE inhibitors in patients who have renal dysfunction, sometimes this will be the best medication for that particular patient. So they'll weigh the pros and the cons and they may still be on it. If they have renal dysfunction, they're most likely going to use Cadopril because that short half-life is going to prevent these drugs from building up too high in the system. However, the fact that it has a short half-life means it must be taken about 3 to 4 times daily. And it only comes in a tablet form. So that's kind of a drawback. If they're in the hospital, they'll have to be switched to a different ACE inhibitor to control their hypertension. The next one that we see used really, really frequently, both in the oral route and the IV route, is enalapril or Vasotec. This one we see used all the time. One drawback to this, though, is it is a prodrug. What that means is it must be metabolized by the liver in order to be effective. So if a patient has hepatic dysfunction, their liver's not functioning very well, this drug will probably not get metabolized, and if it doesn't get metabolized, it's not going to do much good for the patient. So for that reason, if they have liver dysfunction, enalapril wouldn't be the best ACE inhibitor to put them on. And then I've got a couple others listed there. Lisinopril is also very common. Quinapril we see used once in a while. Same thing with ramipril once in a while. But just know they all follow the same rules as enalapril and cadopril. They're all ACEs. Nothing terribly significant with any of them that you need to be aware of. Now the next group of medications is the group that we will put them on if they develop that dry hacking cough. So they'll almost always start with an ACE inhibitor to control heart failure or hypertension or whatever the case may be. If that patient develops a cough, and up to 20% of them do, they take them off the ACE and they put them on an ARB. Now where this is different, they're very similar to the ACE inhibitors, but instead of blocking the angiotensin converting enzyme, it allows one to turn into two, but then it blocks all the receptors that angiotensin 2 would bind to. By doing that, angiotensin 2 just floats around the body and doesn't do anything, and eventually it gets metabolized and disabled, but it prevents the same things ACE inhibitors does. So it doesn't cause a vasoconstriction, or it stops vasoconstriction, stops water retention, reduces peripheral resistance, improves blood pressure. So it blocks the site of angiotensin 2 at the receptor sites. It's just a receptor blocker, as the name implies. It blocks that receptor. The benefit to this is it does not cause a cough because it's not allowing the bradykinin to be built up in the system. So that's kind of the benefit to this group of medication. And again, it'll almost always be used second fiddle to the ACE inhibitors. And that's about the only time these will be used, is if a patient is on an ACE and they develop a cough and it's annoying them, they'll put them on an ARB instead. Same effects though, and they're relatively the same as far as potency goes, just ACE inhibitors are a little bit better at what they do. So the details on ARB, or the deets on the ARBs. Indications, same thing as an ACE inhibitor: hypertension, heart failure, and heart attack, post-heart attack. Contraindications for ARBs are similar to what they were for ACEs. They're still a pregnancy category D, so they're contraindicated in pregnancy and then also in patients who are breastfeeding. We recommend they not use these if there's something else they can use. In patients who are in renal failure. Now ARBs are a little less touchy with the potassium and the renal failure, but we still use them with caution, or cautiously. Their adverse effects come from vasodilation, so the headache, the flushing, hypotension, reflex tachycardia, and then you can add the peripheral edema there as well. Patients will complain of the exact same thing as they did for the ACE inhibitors. They're going to have a headache when they start the medication, might notice a red face, they might get dizzy, stand slowly, heart rate might race for a while, but again, the body will quit fighting these medications. And then they might also complain that like their rings and their shoes don't fit quite as well as they used to. So the drug profile here, the one that your book highlights in this chapter is losartan, and then when we talk about heart failure, I think it talks about valsartan. But these are another drug that's really easy to identify because they all end on that S-A-R-T-A-N, that's sartan. So losartan, valsartan, omeprazartan, they're all the same. These are second choice to ACE inhibitors, and a patient will not be on both an ARB and an ACE inhibitor because it's counterproductive. So also keep that in mind. While it might seem like it's a good idea to put them on both, it's a really terrible idea and we won't do it. So if they're on an ACE, they're not going to be on an ARB. If they're on an ARB, they shouldn't be on an ACE inhibitor. And they're mostly reserved for people who develop a cough during ACE therapy. Okay, this we're just going to spend about 2 seconds on because we cover it in detail when we talk about drugs for dysrhythmias. But we also, they're first line for hypertension too, so I felt like it was appropriate to at least introduce them now, and those are calcium channel blockers. Beta blockers are probably first line for hypertension, and then right behind them are going to be calcium channel blockers because these are just little miracle drugs as well. How they work is they block the influx of calcium. By blocking the influx of calcium, it results in vasodilation, which is going to reduce the peripheral resistance. And there's 2 categories of these. They're selective and non-selective. The non-selective are going to work on both the blood vessels and the heart, and those are the ones that we typically use for dysrhythmias. Other ones work on the blood vessels only, and those are the ones we normally use for hypertension. The ones which act on the blood vessels only are easy to find because they all end in that IPINE, so like amlodipine is a common one, also known as Norvasc, that you will see. So that's those. The side effects all stem from vasodilation, so they're known for causing a headache when first started, some facial flushing, hypotension, reflex tachycardia. This would be a good one if you had to decide between a beta blocker or calcium channel blocker. And let's say the patient's resting pulse is in the 50s, even high 50s to low 60s. A calcium channel blocker would probably be your top choice over a beta blocker because it'll leave the pulse alone. So that's typically when we see these guys used more so. But they are first line. These and the beta blockers are typically where patients will start with for hypertension. And then if that doesn't work, they'll either add an ACE or switch them to an ACE or switch them to an ARB if they develop the cough. So more on these to come, but just kind of introducing them here. This is another one that's frequently used for blood pressure in addition to another medication. It'd be really weird to see just a diuretic used, but it's commonly used in conjunction with something for hypertension. They actually have their very own chapter, so again, I just felt like it was appropriate to maybe introduce them here, but we're not going to talk much about them. And that would be the diuretics. Chapter 28 is going to tell us all about them, but essentially their mechanism of action is to diurese. They cause the body to excrete excess blood volume. By excreting the blood volume, it does so via urination. You just pee out all your extra blood volume. It decreases the peripheral resistance, and it also decreases the stroke volume. By doing that, it's going to lower the blood pressure. Keep in mind that because its mechanism of action is to make the patient void all that fluid out, we like to give it early in the day so they're not up all night. And we prefer not to give it right before a long car ride because it's a really potent diuretic and these patients will be miserable, or they'll just have to stop every half hour to go to the bathroom. The other thing with this is because it's making people pee, if you have a patient who's also confused, make sure there's nothing between them and the bathroom, that they have a clear path, and make sure you have a bed alarm on them so if they try to get up without you knowing and they're unsteady, you can intervene. And again, just have the blood pressure equation there. It's essentially working on the peripheral resistance, which is going to bring down your blood pressure, and a little bit on the stroke volume. There's 3 different types. There's 2 potassium wasting and there's 1 potassium sparing. You're going to see potassium becomes a really big deal with this group of medications, and we'll go into detail on that when we cover them. But the 2 potassium sparing is the loop diuretic, which is the most potent. And then you have the thiazide diuretics, which are typically used for maintenance therapy. Because they're not quite as potent, so they don't cause quite as many side effects, and loop diuretics have the adverse effect of dehydrating the patient if they lose too much fluid. Your thiazides are less likely to do that. The last one, the potassium sparing, produces the weakest diuresis, but the patient doesn't lose all their potassium with their fluid, so therefore it's kind of a good thing for patients to use as well. Okay, the last big group we're going to talk about here are the vasodilators. I told you that was so important. It got its very own group. The mechanism of action for these is simply to dilate the blood vessels, and these result in a very profound vasodilation. Much, much more potent than, say, your calcium channel blockers or your ACE inhibitors or anything else. These are like blowing up the blood vessels. They get them huge, and they're potent, and they're strong, and they're really, really good at vasodilating. Now, with that profound vasodilation, though, also comes some very profound side effects. And this is the reason why these typically aren't used first line. These side effects can be pretty nasty. The first one is reflex tachycardia. The vessels dilate, and they dilate really fast, causes a fast drop in blood pressure, and that really freaks the heart out. So the heart thinks it needs to work really, really hard to beat that blood through faster to try to bring the blood pressure back up. For that reason, a lot of times, and we'll go through this later, but a lot of times we'll give these medications with a beta blocker to control the heart rate as well. The other thing that the kidneys will do, because the kidneys sense that drop in blood pressure, is it will cause aldosterone and ADH to be secreted. It starts releasing a ton of renin to start that renin-aldosterone or angiotensin-aldosterone system running. So it results in a lot of sodium and fluid retention, which then can cause problems too for people with hypertension. Indications for this, so only time you're really going to see these used is for uncontrolled hypertension, so agents where, or cases where other agents don't work, or if a patient comes in with a hypertensive crisis. And we'll talk about that just briefly on your last page of notes, the hypertensive crisis. Contraindications: if the patient's got a low blood pressure, by all means do not give any of these medications because it will just essentially stop their blood from flowing. So if they have a low blood pressure, I wouldn't be comfortable giving this even if their blood pressure was in like the 110s over 80s. I personally would not give these medications. It causes a huge drop in blood pressure. The other thing, because it causes fluid and sodium to be retained, is cerebral edema. So if there's any swelling on the brain, this is absolutely contraindicated because it's going to make that worse. Also, along the same lines with the fluid retention, if a patient has heart failure, this is not an appropriate medication to give because it's going to cause the amount of fluid that patient has in their body to build up and is going to make the heart failure worse. So keep that in mind. There's some times when these are really not appropriate to use. They're really only used in very, very specific cases. Otherwise, they're really not commonly used. Some of the side effects, and again, why these are so terrible to use on a daily basis, would be severe dizziness. Before you give this, especially if it's in a hypertensive crisis and you're getting ready to push it IV, make sure the patient's sitting down or preferably laying down, because if they're standing and you give this, that drop in blood pressure is going to make them pass out. And as they pass out, you're going to have safety problems as the patient falls. Also, if you're giving this orally, so if it's their daily vasodilator for whatever reason, and you give it, know that the first time they get up, so if they take it in the morning and they're laying there watching TV and suddenly they decide to get up, the first time they get up, they're going to get really dizzy from it. So don't discount it just because it's an oral medication. It still causes some pretty significant dizziness. Headache, again, give Tylenol. Typically, if a patient's taking a vasodilator, though, the headache is the absolute least of these patients' problems. Really think critical patients when you think this group of medication. Orthostatic hypotension goes with the severe dizziness. Again, have them sitting down or laying down. Now, the last two we'll typically give another medication with to help combat these side effects. The sodium and water retention we'll typically give with a diuretic because as these vasodilators cause fluid, as the body retains fluid to compensate for these vasodilators, we can give a diuretic to knock all that fluid back out of the body. Same thing with the reflex tachycardia. As the body asks the heart to speed up to bring up the blood pressure, we'll give a beta blocker to bring that heart rate back down so it doesn't put undue stress on the patient. There's two here you need to know. The first one's hydralazine. This comes in two routes. One is an oral route, which is for maintenance therapy, but it's very uncommon to see it used. It might be used for patients who have really complicated or severe hypertension, and it does tend to work really well for patients of African descent. So going back to our people who are at the most or the highest risk African American males, this might be what they're on because nothing else controls their blood pressure. So that would be an instance when you would see an oral hydralazine used. And then for emergency, it's going to be IV. And this is going to be either for hypertensive emergencies, or sometimes we'll use it for hypertension after surgery as well, because anesthesia can sometimes cause the blood pressure to increase. And there was a rumor going around last fall among the pharmacology course that hydralazine could only be given in that intensive care unit. I don't know who started that rumor or why it got started, but I assure you we can give hydralazine on the floor. We give it all the time on the surgical unit. This is not an ICU specific medication. So if somebody tries telling you that, they're fibbing because we give this, like I said, all the time on the floor. Particularly on the surgical unit, we give it after surgery to bring blood pressure back down. But certainly the IV is going to be reserved for more drastic cases. So either an emergency or we have a blood pressure that's not responding to other medications. The pharmacokinetics for hydralazine, when you're giving it IV, it works within about 5 minutes. So make sure that patient's sitting down or laying down so they don't pass out on you. And when you give it orally, it takes about 20 minutes to kick in. Again, kind of think about orthostatic hypotension, and if they're sitting down, they take their pill, and a half hour later they gotta go to the bathroom. When they stand up, they're gonna feel dizzy, especially if it's a new medication for them. So kind of keep that in the back of your mind. And you'll always check the blood pressure before you give this. If it's low, you're not going to give it because it's going to make it even lower. Now the next one, NitroPress. This is the one that's reserved for emergencies only. So this one would be the one that it's only used in a hypertensive crisis situation, which would be probably in the emergency room or within an intensive care unit. This is one we don't give it on the floor because hydralazine works just as good and it's a little bit safer. With NitroPress though, it acts within 2 minutes. So when you give this within 2 minutes, that blood pressure is going to be falling. Now, as that blood pressure falls, I cannot stress how important it is to watch for side effects, have the patient safe, either sitting down or laying down. You certainly do not want to be the nurse that pushes this with the patient standing up and then has to explain why the patient passed out and hit the floor, because that would really make you look like a not very good nurse. Make sure they're sitting down, or even better, laying down. Also, a lot of times we will give propranolol or labetalol with this medication to help prevent against the reflex tachycardia. Those tend to be the two beta blockers that are preferred, although you certainly could give Lopress or metoprolol. It tends to be propranolol or labetalol to help control that reflex tachycardia. Also, keep in mind it's going to cause sodium and water to be retained, so a diuretic with this medication is also pretty appropriate to use. The other weird thing with NitroPress is once it becomes metabolized by the liver, it turns to cyanide ions. Cyanide is often used in suicide attempts as an acid, or it can be used in assassination attempts as well, but it's a highly lethal substance. So keep in mind, once this gets metabolized, it becomes quite lethal. Therefore, if somebody has altered renal function, it wouldn't be hard for them to overdose on this, and it could turn into a lethal state for them. So that's another reason why we don't use it unless we have an emergency. And this would be your emergency, what we call a hypertensive emergency. This is simply a condition in which the diastolic blood pressure is greater than 120 millimeters of mercury. Keep in mind the diastolic is the lower number. The high number, or the top number, the systolic, can certainly be in the 200s with your hypertensive emergencies. I don't know what the true classification for the top number is. Typically what they go by is that bottom though. But once you get a blood pressure really above 180 over 100, be trying to get that pressure down as quick as possible. Hypertensive emergencies typically happen when the patient comes into the emergency department. They might just not be feeling quite right, and they'll check the blood pressure, and that's normally when they find these really, really high blood pressures. It can be caused by a couple of different things. One common thing is stopping their antihypertensive medication, causing their rebound hypertension. It can cause an emergency. Preeclampsia or eclampsia is an OB condition that pregnant women will sometimes contract, or not contract, but develop. Or people who hit their head can sometimes also cause this. And there's certainly other causes too, but it's normally something along those lines. Why we get so nervous is it causes target organ damage. A blood pressure would not need to be sustained that high for very long before the kidneys suffering damage, the brain suffering damage, eyes are suffering damage. So it's something we need to fix as soon as possible. Treatment will always be IV for this. Somebody tried arguing that no, I would give an oral medication until I got the IV started. And if it's taking you more than 2 minutes to start an IV, we need to review skills with you. No, you're going to start an IV and give this IV. We don't have time for the oral medication to dissolve, absorb, and start doing its thing. So you're always going to pop that IV in and get this medication intravenously. Just trust me on that one. The one we give is NitroPress. Again, it's acting within 2 minutes, so it's bringing that blood pressure down the best. With that, a lot of times they might give Catapress to help, not frequently. Sometimes they'll give Catapress depending on the physician, I guess. More commonly, they're going to give Lasix to decrease the fluid retention, though, and labetalol to prevent the reflex tachycardia. So that's more your hypertensive emergency. Think emergency room, potentially in an ICU setting, but definitely something that needs to be corrected ASAP. So, for this last little portion of the lecture, and this is just going to be another 5 minutes or so of your time, go ahead and just grab a blank sheet of paper, or if you printed off that little chart that I created for you from the website, you can grab that as well. But this is just a few of our cliff notes on the different types of medications. The first one we're going to cover are the adrenergic blockers. So we're talking about all 4 categories. I've got them all grouped into just a very broad adrenergic blockers. And we are including clonidine and methyldopa in here, just because they're not big enough to deserve their own slide right now. Remember, with this group of medication, we always use with caution in asthmatic patients, COPD patients, because it's working potentially on beta-2, and it's going to cause bronchoconstriction. We also use in caution with diabetic patients because, again, working on beta-2, it's going to inhibit the liver's ability to release glucose and save the patient from a hypoglycemic episode. And then know the 3 which can be used in heart failure. If it's not one of those 3, don't use it with heart failure. Side effects, I want you to know bradycardia and hypotension, and then also add lethargy and fatigue on there as well. Must be checking the pulse and the blood pressure. If either one is low, blood pressure less than 100, pulse less than 55, you're going to use nursing discretion and not give this medication because it's not safe to administer. And physicians do expect you to be able to recognize if it's a safe situation or not, and then to act appropriately. And there's a spot within all charting that you can give why not given nursing discretion. It wasn't safe. Identification, these, except for catapress and methyldopa, they all end in either OL or LOL. So they're fairly easy to identify, and then you can just throw methyldopa and catapress on their own little card there as the weird cousin. Indications, hypertension, angina, and then after a heart attack. And then the only ones approved, and again, I know this is changing, and in another year I'll probably have to change these slides, but for you guys right now, at this moment in time, I want you to think the only ones approved for the treatment of heart failure is metoprolol, carvedilol, and then that new bistolic as well. Cliff notes on the ACE inhibitors. So these are going to work just a little bit slower because they're a hormone agent. Your adrenergic ones are working on the nervous system, so think of them acting just a little bit faster. If you're having a hypertensive emergency, pushing a little enalapril IV is not going to help you. It's not going to work quick enough. So these are a little bit slower guys. They are still easy to identify because they all end in pril. Remember, ACEs come up in April. And the side effects are a result of the vasodilation, and then a couple other stuff, I guess, as well. But the hypotension, check the blood pressure. If it's low, you probably won't give it. Although it would be much less safe to give a patient a beta blocker if they had a low blood pressure than an ACE inhibitor. So sometimes if you take the blood pressure and say it's resting at like right at 100/70, the physician may still say, yeah, go ahead and give it because it's not quite as potent and it doesn't act quite as quick. So it's something that I would still confirm with the doctor. Do you want me to give this? Do you not want me to give it? Because sometimes they'll be like, yeah, it's okay. And other times they'll be like, no, hold it. So this is one I would just check. Now, if the blood pressure was low, like in the 90s or 80s, then I wouldn't give it and I would be comfortable just not giving it. These can cause a hyperkalemia, so it can cause an increase in potassium. Use with caution. Other medications that increase potassium can also cause a cough or angioedema. First-line treatment for heart failure and hypertension, more so hypertension, but they certainly use it frequently in hypertension as well, particularly as an adjunct treatment. And then the next group are the ARBs. This is, again, a little bit slower because it's a hormonal thing. We're working on the blocking ARBs, the aldosterone or angiotensin II receptor blocker. It's similar to the ACE inhibitors except for they do not cause a cough. And these are also very easy to find because they also end in sartan. And again, you're going to check the blood pressure. If it's low, like in the 80s, 90s, you're not going to give these. If it's bumping along in the hundreds, then it's probably okay to give this group of medication. And then the calcium channel blockers. Although we didn't talk a lot about them, we're still just going to acknowledge them because we're going to talk about them again in, I forget, is it chapter 27 or 28, somewhere in there. Their main action is vasodilation. So because they're a vasodilator, they're going to cause a headache, hypotension, flushing, peripheral edema, and then I'm forgetting one on here. It's also going to cause reflex tachycardia as well. Again, the reflex tachycardia, headache, and flushing are going to decrease over time. The hypotension, the peripheral edema is probably going to sustain as long as the patient is on these calcium channel blockers. So make sure you're checking the blood pressure. If it's low, don't give it. And then there's two types. There's two which can be used for dysrhythmias, and that's dilatiazem and verapamil, and then the ones that are only acting on the vessels are the ones which are typically used for hypertension, and they tend to end in that IPINE, so amlodipine is a common one, also known as Norvasc. The last group are the vasodilators, and they are reserved for severe or uncontrolled hypertension, and they tend to work better for people of African descent and male. They're also used in hypertensive crises, and they're a very potent medication. Their action is strong and their side effects are harsh. Because of their harsh side effects, make sure you're thinking patient safety, have them sitting or laying down, be monitoring for the reflex tachycardia, and then be monitoring for the fluid retention. For the tachycardia, you'll probably give some sort of a beta blocker with them to help decrease that. And you'll probably give some sort of a diuretic to help prevent against the fluid retention as well.